Morning, and thank you, Dushyant, for making me. I've been wishing to, I've been missed coming to HCG so far, but finally the time has to come, and then that too. I think we are waiting for the new hospital and new setup to start with the new hall, so that we can all sit nicely and be here. My job was to talk to you about something new, something not new, I would say, something more. I can start, no? Okay. So, something I would say slightly out of the box. You have to think in this area. But I don't know how much it will be practically useful at present. But I just want to take you through the role of, status of the reconstructive transplants. In reconstructive transplants I would just go through this evolution of the composite tissue allotransplantation in all the areas, and then take the advantages as well as the issues with CTA, and then what is the current role. Especially put some thought process in the laryngeal transplants, because that has come up again, and then in last 1 year, interest in that, and everybody is talking about it across the world. So I just take you through that. Now, if you look at look at the organ transplant history in the composite tissue alert transplants, it started this is I don't want to go through all the things, but if you can look at it, the first hand transplant was done in France, and then the laryngeal transplant same time 1998 by Marshall in US, and then face transplant, double hand transplants was in Germany, and then face transplant again in France. Europe has been the leader, because maybe some amount, if you look at the history of evolution of composite tissue transplants, the animal experiments and all were much done in US, whereas the actual thing happened more in Europe, because maybe the regulations were slightly less there to start on experimental surgery. And then this is the first hand transplant, and the date line. Now, it why are they important? It is something called a medical miracle. When you look at the kidney transplants, one of the surgeries that fetched Nobel Prize was transplants, because the first kidney transplant which was done was the person who did it got the Nobel Prize. So that was something which has transformed the medical scene, surgical scene. Then you can take a tissue and put it somewhere else and make it work, and it has saved numerous lives across the world during this time. And then the number of organ transplants across the world in now is huge number. Kidney leading the show, then the liver, and then the heart and lungs, and you name the organs, it is being transplanted. And then the problem is with the transplant is this one. Somebody's organ you need to have immunosuppressants to prevent its rejection. The first transplant was done in an identical twin. That was totally different, but when it is from a non-identical person, there needs to be immunosuppression, and this can cause definitely problems, starting from all the lifestyle diseases, so-called lifestyle diseases like hypertension, diabetes, you name them, it can be come out of this immunosuppression. Cancers can come. So then the question comes, see, heart failure, kidney failure, liver failure, patient will die. So you need to have a transplant. So the cost benefit or risk benefit thing is totally different. Whereas in things like face and all those things, it's not a non-vital organ. So you always question, is it needed? And then then it comes vital or vital, essential or non-vital. Now, having a laryngeal voice is also essential. Having a normal swallowing is essential. Having both hands to do daily work is essential. So these are the essential transplants. Then that was the logic behind starting the composite tissue allotransplants, and this was the first partial phase in 2007, and then the full phase. And this was the one our hand transplants patient. This was Manu and this was Abdul, who it was in 2015, 10 years back. It was exactly in January 2015 we did the first, and then you can see them back into normal activity. Now India is the global leader now. That is something which we can be comfortable with. That in hand transplants, the if you look at the total numbers, we have about 70 odd in the country, which is the recently it has not reached the top, but last few years we are the top, and our center is the largest center in the whole world now, for having done 15 in Kochi and 3 in Delhi, so 18. So we lead the whole world in hand transplants now within the 10-year period. Now, advantages of transplants. You just see this picture. See, if you look at any reconstructive methods, you won't be able to achieve this with the transplant. See, neurofibroma is huge things. You can get a nice sort of whatever you do, several surgeries, you cannot achieve what you can achieve with face transplant. And this is another one. I'm just showing you some pictures. This, you see this reconstructive methods, you get it this one. I don't think anything can match composite tissue allotransplants. And this was, see, these are two of our cases. This is routine, 15 surgeries for this lady to reach there. This was another case which we did. But you don't get dynamicity in this. That's a problem with this. So dynamicity, you can get it with a face transplant when the facial nerve is attached, hypoglossal is attached, so you get that. That is advantage of that. And function is incomparable with the face transplant. I will skip this because of, anyway, I just want to, that was just saying that facial nerve function, everything comes back. And then this is a laryngeal transplant. It has been a long road and rough road, but every inch was worth it. That is the way. You ask any of these hand transplant patients, two of our patients have developed PTLD and one had gone for lymphoma. Still, they will say their life is worth it. That is the way it looks like. And then issues with CTA let us look at the topic today, is that can we do it in head and neck cancers? Immunosuppression and cancer is the greatest problem, because now if you look at it, the cancer immunity and the tumor, the VCA immunity are just the other way. When you want to suppress the immunity, the cancer grows. And that is a main issue which we find it difficult. The logistics in transplants again is a problem. See, imagine you have something you have to do transplant. You don't know when you are going to get this donor. So your cancer won't wait till you get the donor. So that is going to be a big issue if you are thinking that you are going to utilize the transplant in this. And then each procedure needs huge resources, huge everything. So it's not going to be practical to use this in the management. And then problems with the procedure, like this lady had a face transplant, the first one. She had a lung cancer later on after 10 years, 12 years, and she died. So those things are a big issue. What is the current role now? I will come to that. The larynx. Spend some time on that. This is a scalp and skull transplant, but again it was done in a cancer patient, leiomyosarcoma. But he was on immunosuppression after kidney transplant. So if you look at the current scenario, many of the organ transplants that have been done in cancer had a transplant of some other thing and they were already on immunosuppressant. So you are not adding some immunosuppressant regime to this patient. So it is quite safe in that way. That's why it was being done. And in larynx, I just want to take you through this because a lot of interest, and I'm sure the whole crowd will be interested in looking. The first one was in 98 Strom. This patient was for laryngeal trauma. Again, 12 years later, it had to be explanted because of the chronic rejection. The second one, 2020, is still doing very well. This was one. Now, there's a lot of confusion in the number of laryngeal transplants across the country. I'm citing all the literature that is available in laryngeal transplants till date. This was one global experience thing where they had pooled in all the number of cases what was available to this group. There's 11 patients, out of which 4 were in US. I think 2 were in US, and then Colombia 5 and Poland 4. This Colombian thing was the one which attracted everybody because Tintin, their group had initially said that they had 28, but if you look at this one, it is 5 cases they had documented, and out of which 4 patients had radiation and cancer. Rest is all for trauma. And this is again China. This doesn't come into picture at all. I just went through the whole thing. Then this was a single case when it was done for pure cancer, laryngectomy and laryngeal transplant. And then I was fortunate to review that Frontiers thing which came. They have added 2 more cases, again cancers. It doesn't come into general sort of literature, but these are all 3 cancers which they immediately did a laryngeal transplant. I don't know how you would do it or who would think of doing it now with the knowledge of the immunosuppression causing damage, aggravating the cancer. So these are all the 3 cancers I told you about the Frontiers paper. They were looking at the thyroid function after laryngeal transplant, which is brilliant because the patient had the donor had a Graves' disease, the recipient also developed Graves' disease. That is the way it was working in the second patient they had. The other one, this is a laryngeal transplant. This is the one which attracted everybody's attention because it can be done in cancer. That was Mayo Clinic last year, immediately after laryngotracheal resection for malignancy. But the small print, if you look at it, is the patient was on immunosuppression after renal transplant. So there it's quite okay. You can go ahead and do that. Not in these cases. And this was another one, the first laryngeal in the ECLAR group. Then this if you want to undertake this one, I would suggest to go through the Mayo Clinic paper, and this paper gives excellent sort of technique. It's very simple. It's nothing much. This is a patient who had a kidney transplant. Then he had this thing. See, vascularity is based on superior thyroid, inferior thyroid, so it works. And the nerve is and they had taken the entire skin, so it also works. And then the nerves are the issues. I'll tell you the recent Mayo Clinic. Again, this was the way they transplanted. I will overall results. If you look at it, there are 3 deaths in that 11 group of patients. And if you look at the phonation, I don't know whether it is very clear. You can see that the laryngeal sound coming back is the one which always we worry about. Everybody says that all the patients have return of function, and only 3 or 4 patients out of this 11 needed tracheostomy at the end. So probably all these functions come back, but not in the real sort of sense. And then the other branch which has, there was one group, I don't know, I think he came to TMH once, is it Peter Dallaire? He came to, I think Prathamesh Pai called, and they have done 5 tracheal transplants, and they all did one, but it has not caught across the world about how do you do the tracheal. The way they did was to put the trachea into the main problem in the trachea. See, larynx is okay. You have the vessels, you have the superior trachea, superior thyroid, inferior thyroid, but the trachea doesn't have vessels. So you need to take the trachea and then put somewhere else and get the revascularize and get it into the thing. That is how the Peter Delaire's group did 5 cases, and they could withdraw immunosuppression later on by because of it naturally the mucosa grew over that. That's what they claim. Again, but now this is also disputed. Now, if you go through all this literature, trachea also can be. Last Mayo Clinic and other clinic thing, if you have the vascularity out of the larynx coming out in the trachea through the superior thyroid and this thing, and the best part is that you take a cuff of esophageal mucosa and trace the esophageal vessels down, and you can have a vascularity from below also. So you can transplant, in fact, entire trachea based on the superior thyroid and inferior thyroid as well as the gastric vessels. That is what one of the cases did. The entire tracheoesophageal thing was transplanted. So that is also possible. Now, restoring the vascularity, as I told you, is simple. Nerve is the main issue. Now, the greatest thing is that we know much more about the neurotization of the larynx, and then the studies out of which you don't put the recurrent laryngeal nerve directly to recurrent laryngeal nerve, but what people have been starting to do is that put the ANSA into the selective sort of reinnervation there also, where the abductors are connected to either vagus or phrenic, and the adductors fibers are connected to the ANSA. So the principles of laryngeal reinnervation has been adopted by few of the people here. So that is a welcome thing. So your chances of getting a functional larynx might be better in future laryngeal transplants because of the understanding of this one. And then tracheal vascularization, as I told you, you can embed that, but again, like what we are doing that, and this was one of our cases, first tracheal transplant which we didn't was not successful in the long term because the patient developed a severe bleeding after about 2 months, and then she died. But again, we put it in the forearm and got the vascularity done. Now, single stage tracheal transplant, as I told you, has been done. Now, the regime of immunosuppression is same. Just think that if you are doing a kidney transplant, what will you give? You will give to all these patients. Even hand transplant, you just give the same thing. There's no difference. And your nephrologist or immunologist will help you out. If you ever think about it, don't think too much. Get a nephrologist with you in the team and get it done. Monitoring and managing in laryngeal transplant is easy. Mostly endoscopic this thing, and then your symptoms like increasing hoarseness or slight amount of extra cough will appear out, and then you can give bolus injections and get away from the rejection. Coming to the last part, what is the lessons that have been learned so far when cancer is concerned and the composite tissue allotransplants are concerned? Laryngeal transplants are possible with predictable success now. So there's no doubt. There are a number of transplants that have been done. And if you look at the face and this one, face is also standard, hand is standard, larynx is also getting standardized to a great extent because of these experiences. The functional rehabilitation, as I told you, is better with larynx now because we know we have slightly progressed in the understanding of neural rehabilitation of the larynx. And lastly, long tracheal segments can be transferred with the vascularity. So these are the 3 things that has emerged last decade in laryngeal transplantation, which might help you to get into the field whenever it is there. And again, what are the indications? I would say if I would be doing a laryngeal transplant, if the patient is a severe laryngeal chemical, patient has got a PEG, patient has a tracheostomy, depending upon it's a cripple, and then ready to accept the problems of immunosuppression, I might suggest that we can try a laryngeal transplant in that particular patient, in a benign patient. And again, you have to counsel. Even our hand transplant patients, we counsel so much that are you ready to have these problems of lifelong immunosuppression and its perils. We show them now currently the problems faced by our patients. So they have to have a real understanding that you are going to, you are a healthy person, you are making yourself unhealthy by doing this transplant. So if you are ready, you can do it. And in cancers, it's Again, low-grade cancers, it is okay. Where chondrosarcomas or adenoid cystic carcinomas, it is quite maybe acceptable. Not in high-grade cancers. Patients who have done 5 years of this thing after cancer, laryngectomy, any cancer for that matter. But the problem there is, you imagine the patient who has a laryngectomy coming to you after 5 years, then asking for it, you have lot of issues there. First of all, you have to say that the patient has to undergo this one and have to have immunosuppression. You don't know what is going to really happen. Secondly, you don't find the nerves and all those things. So it's a problem. Finding the nerves will be a problem in that. And then if I had a chance to go back to our patient, we would have done that, because we did this tracheal transplant with a hand. The patient had to undergo a laryngectomy on the table because of close margin. Had we known at that time, and had we thought in this thing, I would have put this patient for a laryngeal transplant now, because the adenoid cystic carcinoma going from the larynx up to the carina, where you have this technique now. I know that I can do it now. And the best part is that the patient will receive radiation, postoperative radiation, which will reduce the immunogenicity of the entire transplant. So again, the chances of that necessity of full-blown immunosuppression might be less. So this is where we have to think. These cases, judiciously if you think, and then have a entire thought process of the whole team, these are the cases you might be able to again do with the current knowledge of laryngotracheal transplant. And future local delivery of immunosuppressants, less toxic immunosuppressive agents, and developing these are all in the pipeline. It might work. And again, when immunosuppression is not a issue, definitely I can assure you that composite tissue allotransplant will be in the highest grade of reconstructive armamentarium, because nothing can, like we all are reconstructive surgeons, we have tried that, all these face things and all those things, you cannot replicate what face transplants does to you, because beautifully it heals. The only problem is the immunosuppression. And then larynx and trachea, definitely yes. And then look at this last this is the last slide, this thing. Can you move? Yeah. The tongue we see, we put all these flaps, we saw all the flaps. Will any of that tongue, any of these flaps, if you have a total tongue defect, will any of these flaps do this, what this does? It doesn't. And there are 2 transplants done. One was in 2008. I would say it was sort of unethical type of study. At that time it was covered by ethical council and all those things, but a committee. The patient died 1 year later with a recurrence. You don't know whether the cancer was brought in by the immunosuppression or not. We don't know. The second case was good. That is a part of the composite transplant of the face, maxilla, everything with the tongue also was there, and then hypoglossal was connected, lingual was connected, and the patient is surviving with the good tongue function. Good tongue function, speech is good, and movements are good. So there is evidence that tongue transplantation will work. If anybody is interested, this is a beautiful article which gives all the animal studies and all those things. So just keep your mind open. You don't know when science progresses and the immunosuppression comes down and all those things. That is why we have to be equipped mentally to do a transplant at some point. And it's not going to be very difficult, because technically it's not that challenging. You have to have a good team. Another thing, you see this neurofibromas like this. Will any of us be able to give a good answer to this? None of us will be. But imagine you do a face transplant. It's a single window, single step sort of answer to this. But will I do it? I will not do it now, because see, he is otherwise healthy. Face transplant, the patient can die after 5 years or 10 years with the sequelae of, and then any infection occurring can be catastrophic. Can have a CMV, and then they have to have lot of money with them to get out of the problem if you do it. So I think you have to be careful about that. Thank you very much.